Hi, good afternoon. Welcome to the Key to Risk Adjustment. I'm your host, Sean Tatum Williams. And on today's episode, we're going to pick up and start to begin to talk about atrial fibrillation and the impacts of atrial fib and how to document it appropriately, what is expected in the documentation, and those tips and tools to help you be successful. Today's segment is being brought to you by Tatum Risk Adjustment Consulting. For all of your risk adjustment consulting needs, please reach out to Tatum Risk Adjustment Consulting. Their number is 833-843-2033. Again, that's 833-843 code CODE. And in Tatum Risk Adjustment Consultings, they offer medical billing and HCC coding, provider credentialing, revenue management cycle, and practice management with offices in Houston, Dallas, and Corpus Christi. And now we'll jump right into today's show. Let's see who's joined us online on Instagram. I'm excited to be with you this afternoon. I'm really sure that you all have had a great week, and I am going to jump in here. Uh-oh, I think you can hear that back end. Uh-oh, let's see, how can I join? Okay. All right, so we'll jump right in. So, brought some notes with me this week. Wanted to make sure that I was fair with all of my listeners and that they were able to gain as much knowledge. So September is AFib Awareness Month, atrial fibrillation. So let's get a definition of atrial fibrillation. So this is the disorganized atrial cardiac rhythm that can lead to the development of clot formation in the heart, which poses a threat to stroke in the event that the intracardiac clot where it is to be injected to the brain. Wow. So couple of things to kind of jump into that. I do have a few statistics that I wanted to share. First, atrial fib is one of the most common cardiac arrhythmias. And about 2.7 of 6.1 million people in the U.S. have AFib. I know some of you have seen this on the news. I know some of you have family members, and maybe even some of you all who are listening today have been diagnosed with AFib. Our show, The Key to Risk Adjustment, is specifically geared for physicians and their mid-levels and any of those CDI professionals who look to broaden their knowledge. Again, the key to risk adjustment is to keep educating yourself. So as we continue to keep educating ourselves, let's talk about some general things that you need to know about AFib. So one, it can be long-standing and persistent. And what long-standing or persistent AFib looks like is longer than a year duration of patient who remains a candidate for intervention, such as maintaining their sinus rhythms and other rhythm control interventions. So when you think about that long-standing persistent, this is what I like to remind my providers. This is some of the documentation you want to include in your clinical documentation when you're coding atrial fib or AFib. If it is long-standing, meaning that your patient has been dealing with this condition or you've been managing it for over a year, then this may be considered long-standing. And in your clinical documentation, that is how you would want to indicate it so that it could be coded to the highest specificity. Therefore, when it gets to your payer and on to CMS or HHS, it is accurately coded so that it can have the appropriate risk adjustment factor for your Medicare enrollee who has to be or who happens to be inflicted with atrial fib. Now, there are three others within the AFib, and the other is going to be proximal. So when we talk about proximal atrial fib, it's an episode of AFib so it has any duration and frequency. It could be spontaneous. And it returns to normal sinus rhythm within 7 days. So I think that's a key point to think about when you're trying to determine where your patient is in their AFib diagnosis. Again, long standing is they've had this condition, their normal sinus rhythm has been out of whack for longer than a year, then we may look at proximal. And a proximal, again, the patient is returning to normal sinus rhythm within 7 days of the initial incident. So thinking about that, if your patient is presenting, they may have presented in an acute setting, such as a hospital or an urgent care setting, with the attack of the AFib, and now 2 weeks later they are in your office and they are in normal sinus rhythm. So persistent AFib may then be the appropriate diagnosis or documentation that you need to have in your chart. I would certainly want to remind my providers, it is very important. This is what I like to call a Kodak moment. Say I said it, write it down, take a picture. When your patients are discharged from the hospital, you want to make sure that you're getting those discharge summaries. If you have access to the hospital in which they were inpatient at, work with your staff to make sure that they're logging in and downloading those records for the continuity of care. And it can help you in that outpatient setting with your appropriateness, if you will, on your clinical documentation and the consistency of that continuity of care. So next we'll talk about persistent AFib. Now, persistent AFib lasts longer than a week, but less than a year. So first we talked about long standing, which is greater than a year. Then we talked about proximal, which is less than 7 days. The patient has returned to normal sinus rhythm. And then now we're talking about persistent. So this means it's lasting longer than a week, but less than 1 year. And it also requires some intervention to return the patient to normal sinus rhythm. So again, we've got proximal, persistent, and now we're going to talk about permanent AFib. So permanent AFib is chronic. That is a chronic condition. And we talked last week about the hierarchical condition categories, are those HCCs. And many of those HCCs, well over 9,800 of them, chronic conditions. So in this case, permanent atrial fib is longer than a year duration with a patient that is no longer a candidate to return to normal sinus rhythm, or they're not a candidate for other rhythm control interventions. So here we've got those 4 different, if you will, stages of atrial fibrillation: proximal, persistent, permanent, long-standing. And again, thinking about that, what needs to be in your documentation? And I want to thank all those that have joined us so far this afternoon. I also want to share this with my friends and family to make sure that they're joining in this afternoon. So as we talk about atrial fib and the impacts of atrial fib, I want to make sure that you all are with me. So give me a moment as I also share this with friends and family. Trying to get all those good folks in here, and I appreciate you pausing with me. Send me a shout out. Also, remember, you can send your questions to Med Center Billing you can send them to ctatum@medcenterbilling.com, and I can answer your questions live on air. All right. I was looking up for the time, so you'll have to keep me on time this afternoon. All right, so let's talk about the documentation requirements in order to have clear, concise documentation when coding atrial fibrillation. One of the things is you want to document all your findings, any labs that have been done, any EKGs, any echoes that have been done on the patient. You want to make sure that those have been reviewed and that they have been documented as to what the findings from those labs were. And again, that needs to be done by the clinician. There are some labs and some tests that can be reviewed by other qualified healthcare professionals. But in this particular sense, we're looking for the PCP of record, or that primary care physician. Or if you remember last week, CMS and HHS likes to think of those providers as helicopter parents, right? If you are a primary care physician and you have managed Medicare lives on your case index, they, and by they, CMS and HHS expect you to be a helicopter parent, hovering over the situation, making sure that everything goes according to plan. Oh, you didn't pick up your medication prescription. So in many of the EMRs, you're able to log in to local pharmacies and confirm whether or not your patient actually filled the prescription. Some of the health plans have really advanced some of their detailed reporting and analytical reporting that they provide to you and your staff. And it is important that you take a time to read those reports, incorporate them into your day-to-day, as well as into your encounter with that face-to-face patient, so that during that encounter, it's an opportunity for you to document all of those chronic conditions that you're managing for that member and make sure that it gets coded to the highest specificity so that when the payer receives it and forwards it on to CMS, that they do have the right diagnosis for the right patient so that they can allot the correct expenditures for the next year and caring for that patient. All right, let's get into a little bit more of this documentation requirement. So another thing that you may look when me or other CDI professionals are reviewing our providers' medical documentation, we're looking to see if they noted right in the exam or in the review of systems. In the exam, did they note that there was an irregular pulse? That is a flag. That's a key indicator, right? That's a flag for a clinical documentation professional reviewing your medical record to say, hey, I need to see here, is there something else here that may have been missed? That is also part of that supporting documentation if you're coding atrial fibrillation or long-standing atrial fibrillation or proximal or persistent, either of them. If you're coding either of those, in your documentation, you're going to want to make sure that you have some of these key pearls. Here we go. Kodak moment. Again, was there an irregular pulse? What about edema? Most every provider I know, if they have patients who are already troubled with some type of cardiac disorder, they're always going to look at their feet during that encounter, right? During that physical exam, it is very telltale when looking at that patient's exam. Doing a pedal pulse exam, I've heard is from my providers, is one of the best telltales. And we're going to have some of those providers on who will share with you their own experiences. Hey, y'all, thank you for joining. I see you there, Shay, and thank you for joining. All right, so another thing that we want to look at in the documentation or that we want to ensure is there is if there were diagnostic testing such as an EKG, like a 12-lead EKG, they're looking for the absence of P waves. So again, my CDI professionals, if you're reviewing an EKG for your provider or with your provider, one of the things that your provider is going to be looking at when reviewing that in order to diagnose appropriately atrial fib is the absence of P waves and the R to R intervals that don't have a repetitive pattern, right? So that repetitive pattern, so there's a skip or there's a slow. So I've heard providers give a lot of different explanations. I am not a provider and I am not my expertise, but I promise you we will have those providers on who can dig into that. Now, with that, typically the QRS complexes are narrow and they're less than 120 milliseconds in duration. So again, when reviewing that 12-lead EKG, there's some parameters that are within there. One that would like to be seen within the documentation, or clearly if the provider just notes that there was absence of P waves and or the R&R intervals don't follow a repetitive pattern, that then indicates that this could be atrial fib. Also, if they've had an echocardiogram or a transthoracic and or transaxial esophageal to determine the structural integrity of the heart. So those tests really help our providers dig in to see the structural integrity of the heart, as I stated, but it also helps to further define, if you will, that level or that stage of atrial fib. They can look at that and they can determine, is this persistent? Is this proximal? Or is this long-standing AFib? Also, blood work. The labs that you draw on your patients, when getting those labs back, we're wanting to look for underlying thyroid dysfunction, anemia, infection, and other electrolyte or glucose abnormalities. So when looking at those, hey y'all, thank you all for joining. Please share with a friend, have them join. I'm so excited that you've joined me this afternoon. So again, back to blood work is also one of those key objectives in considering of the diagnosis for atrial fibrillation. So again, in the blood work, they're looking for underlying thyroid dysfunction, anemia, infection, and other electrolyte or glucose abnormalities. All right, so I'm going to send over this to just a couple of others, invite them to join us, make sure we've got the right folks on here. Let's see here. And thank you again for being patient with me. I want to see your questions. If you have any questions about coding atrial fib, we're going to get into how to code that here in just a second. But I also wanted to, if you have questions or you have friends or family, and my CDI professionals that are on our podcast today, please don't hesitate to chime in and drop in a few of your questions so that I can answer those. I will happily do my best to answer those live here online. And then I will also circle back and answer any of those questions at a later date for those of you who I'm unable to answer them all at this very moment. All right. Let's see here. We'll get to the next. All right. So we were talking about documentation requirements as it relates to clinical documentation for atrial fibrillation. We talked about some of the common physical exam findings, such as irregular pulse, edema, jugular vein distension. Those are all things in the physical exam that a provider might document. And again, also we talked about the EKG and what providers are looking for when reviewing that EKG, as well as the echocardiograms, labs such as blood work. And then last, looking at those opportunities where if you really feel that this patient, maybe they've come in and after a hospital stay in which they were diagnosed with AFib, and now you, the cardiologist, maybe it's not the PCP, maybe it's the cardiologist whom which they're following up with, and that cardiologist from time to time has different specific tests that they may administer in order to determine the most specific and accurate diagnosis. So with that, they may have your patient wear a halter, a cardiac halter. We've seen those things happen quite a bit. And that also gives more opportunity for the provider to help clearly diagnose what those opportunities are. So here, I wanted to now jump into other documentation findings that we might expect to see within your clinical documentation as it relates to atrial fib. So one thing is obviously the diagnosis clearly indicated in the chart. I want to pause here to kind of remind our providers of the importance of clarity and concise documentation. So we're talking about atrial fibrillation, and we're talking about documentation requirements, and we're talking about findings from labs, blood work, test, maybe heart test, heart monitor test, EKGs, those type things. One of the things we see with some of our providers who are still utilizing paper charts, and yes, there are providers that are still using paper charts. With those providers that are using paper charts, you're still using a lot of acronyms. And trust me, you have a lot to document, and I'm all for it. please use your your acronyms, but use the right acronyms. Don't shorten them. Make sure they are the clinical appropriate. Some abbreviations overlap. And so we want to make sure that we are using the appropriate documentation. Keep in mind, your medical record needs to stand the test of time, and it needs to be legible so that any other person reviewing your documentation has a clear understanding of how you have managed and or treated that particular patient for that particular encounter. So if you go back and look at your documentation and you are having a hard time deciphering what you wrote, you may want to consider getting a scribe. And we will have some opportunities to talk about that in other podcasts and the success that some providers have had using a scribe. Some of my providers use programs that can help them with clinical documentation and getting everything they need in per encounter, such as Dragon. Dragon is another one of those that can help providers get their documentation out and into the EMR. And again, with our sponsor, Tatum Risk Adjustment, they definitely work with providers logging in and with a business associate agreement, working with that provider to ensure that the clinical documentation supports the diagnosis codes in which they have put on their claims. And they can work with them pre-claim or retrospectively after your claims have been done and reviewing the documentation. Oftentimes, what I know they've found is an opportunity in the chart where there were things that were documented, diagnosis clearly documented, treatment plan clearly documented, but it didn't make it to the claim. And sometimes just explaining why those other conditions that you documented for that encounter, but they were not the initiating reason for the encounter, oftentimes don't make it to the claim. So we want to talk about that a little more, and we will today just a little bit more, but in our going forward podcast, we will have deep dives into what didn't make the claim. And I like to call those missed opportunities. And I think you all have heard those time and time again, even with the payers that you work with and their educational teams. But those missed opportunities are huge. So back to documentation as it relates to, hey, Jackie, thank you for joining. Hey, Lollipop, thank you guys for joining. I really appreciate joining me, Sean Tatum, your host of The Key to Risk Adjustment. And the key is to keep educating yourself. Now, documentation findings. Let's get into this, right? So chronic diseases like AFib must have a valid treatment plan in order to be considered as an active medical problem. So let's dissect just that part here just a little bit. Oftentimes when I've reviewed medical records and my staff have reviewed medical records, they're able to see clearly what the doctor was trying to convey in the documentation. But trying to convey and conveying are different things. You may have a coder or a certified coder biller in your office who may query you from time to time for clarification to make sure that what you were trying to document on the chart is actually what was documented clearly so that it can be coded to the highest specificity. So again, making sure that there's a treatment plan to that clear and concise documentation. So as we mentioned earlier, from the physical exam, the provider may note edema. And if they note that edema, then they're also going to note, right, that where, specifically in the physical exam, was it right, left foot, right, left foot. Was it right foot or was it left foot? Those type things, adding that additional color to the documentation. Also, in the treatment plan, they're expecting to see certain forms of treatment. I'm going to list a few that are very common that really will close that gap as to here is the diagnosis and how is that being treated and or managed. So with atrial fibrillation, medication is part of a treatment. Referrals are part of a treatment. They may refer the patient to a cardiologist who is then going to manage their care. Do you remember what the cardiologist is? For those of you that joined last week, if you'll recall, the PCP, as I noted earlier, is the helicopter parent, right? They're hovering over the situation and they're making sure everything goes according to plan. But at some point, that hovering PCP is going to have to send their patient out to a substitute teacher who's also going to review them for whatever medical condition in their specialty. They're going to document it as well to the highest specificity, and they're going to code it and submit that claim to the payer, and that then should also move on to CMS or HHS, whichever payer, whether they're Medicaid or Medicare, it will flow through the payer and on to CMS or HHS. And then ultimately, if appropriate, it would fall into the appropriate HCC category and be calculated into the overall risk adjustment factor for that individual Medicare beneficiary. So I want to say some shout outs to, let's say, Rich, and a couple of other shout outs to folks on here this afternoon. DJ Tony, thank you for joining me. Thanks, Candy, for joining. Hey, Skrilla, thank you. He's here in the booth with me. It's a couple of Forever Candace. Thank you all. So getting back to this, make sure you're sharing with a friend, share with your doctor, share with their nurses. Tell them to join us. We're live every Thursday, 4 o'clock. All right, so other things that we're looking for in the documentation are going to be common treatment modalities, such as those specific medications. So the medication that not only is there a medication documented that it was prescribed for the patient to treat the AFib, but was it a beta blocker or was it a calcium channel blocker? Those specific medications are those that look to say, okay, these treat atrial fib. So I've got a diagnosis of proximal atrial fibrillation, and I've got a prescription written for a calcium channel blocker, and now I have diagnosis and treatment, which then allows for that to go out to CMS and to be validated and ultimately added to the patient's overall risk adjustment factor. Other things that may be noted as far as medications are antiarrhythmics, as well as anticoagulants, which help to reduce stroke burden. So remember, CDI professionals, my docs are going to know what prescriptions, right? But for my CDI professionals, I want you to lean in with me right here. Lean in and just remember those clinical indicators that will be within the chart. Right? So the treatment, and what was the treatment? The treatment was a beta blocker or an anticoagulant. And with that, we want to make sure that we are making sure we code those to the highest specificity. If the documentation isn't clear, then we want to make sure that we query our physician. So next, other things that we may see as common treatment modalities are going to be procedures with with a direct cardioversion, with or without transesophageal guidance. So catheter-based ablation. So again, a procedure that goes into the vein that is then opening up that vein and allowing for that blood to flow through freely. Also, it's key, and I sometimes take for granted that I assume you know that the diagnoses are expected to be in the current ICD-10 form or ICD-10 CM. So that we want to make sure that you are using the correct ICD-10 codes. And if you don't know the right code, then just make sure that you've documented very clear and very concise, using some of those tips and pearls that I noted earlier, and that it's during a face-to-face encounter. Now, since the public health emergency, or since, if you will, COVID, right back in 2020, CMS started to enlighten, or rather lighten some of the parameters around capturing chronic conditions that relate to risk adjustment. One of those, if you don't know, this is what I like to call a Kodak moment. Say I said it, write it down, take a picture. Here we go. During the public health emergency, CMS is now allowing for certain conditions that fall into the HCC category to be captured during a telehealth visit. That's right. Now, what's required, I need you to listen. What's required for that telehealth visit is that there is audio visual between the provider and the patient. So if they've got a cell phone and the provider can see and hear the patient, as well as the patient can see and hear the provider. Some of my providers have gotten really creative with that during this public health emergency in order to be able to meet the needs of their case mix index. And I would love to share some of those with permission from some of my providers on a later show. Certainly inbox me, send me questions about that. I would love to be able to answer those. So again, it needs to be a face-to-face encounter, or it can be a telehealth encounter with audio and video, and it needs to be documented by one of the following credentialed physicians. It must be an MD, a DO, a NP, or a PA. Those are the only physicians in which can document that condition and for CMS to recognize it and add it to the risk adjustment factor for your individual Medicare enrollee. Now, let's talk about some subject documentation considerations as we wrap up. How much longer do I have? 1 minute. All right. So we've got 1 minute before we wrap up. I will continue this, and you will certainly see this on our website, which is www.mccitx.com. And log in, click on demand, and you'll be able to. So these are not uploaded until Friday afternoons, but you'll be able to catch us on Apple Podcasts, Spotify, and Google Podcasts. I want to thank my sponsors for today, Tatum Risk Adjustment. I want to thank Afro-American Barbie for joining. She's one of my CDI professionals that I hope can get on my show for CDI Professional Week next week. Thank you for the Key to Risk Adjustment 30-minute jump into AFIB. I look forward to seeing you next Thursday at the same time with the same energy. You have a great week, and remember, the key to risk adjustment is to keep educating yourself. Have a great week, y'all.